Welcome to both the real world, and we're so delighted to have Klaus here in person, and also to the virtual world out there. I'd like to acknowledge the traditional custodians of all the unceded lands, skies and waterways on which Deakin students and teachers come together as we learn and teach through virtually and physically constructed places across time. We pay our deep respect to the ancestors and elders of the Wadawurrung country, the Eastern Maar country, and the Wurundjeri country. This is Wurundjeri country where we are now, as well as the traditional custodians of all the lands on which you may be learning and teaching, where education has taken place for many thousands of years. It gives me great pleasure to be hosting this seminar and to have Klaus Hoeyer come all the way from Denmark to give this presentation. Klaus is going to talk about data paradoxes today, the politics of intensified data sourcing in contemporary healthcare, and I think there's also a book. So, we'll come to that in a moment. And we're also joined by discussant Radhika Guru. So, Klaus is a colleague, and a dear colleague and a professor. He is, I've been working with you for a little while now, and Klaus has a background in medical anthropology, but his focus is data, and I have learned so much about what lies beneath. When Klaus turns his research attention to data, it just seems to open up worlds, and I'm very confident that in this talk, worlds will be opened up. He's at the University of Copenhagen, of course, and really draws from science and technology studies, which is why we have the lovely Radhika to be discussant. Now, Radhika, got your bio, but again, I've been working with you for a long time, and also very interested in data, also very incisive, and coming from a slightly different perspective, the education perspective, the education policy perspective. So I'm really interested to hear both what Klaus is going to say and how Radhika will respond to it. Now, before we move on to the to handing over to Klaus, I will give some sort of housekeeping because this is a hybrid seminar. So we've got people in the room, and you're in a position of privilege. You can interrupt and wave and do whatever you want at any time, and build the internal atmosphere. We've also got people online. I will be monitoring chat, and there will also be a Q&A. So if you have any particular questions for Klaus, please use a Q&A to ask questions, and then when we come to the participant part of the seminar, we will be able to find out what they are. Of course, everyone's welcome to put the country on which they're on into the chat as well too. So, thanks again for coming, and let me hand over to you.
Well, thank you very much. Thank you both for the generous introduction, for the ability to be here, and thank you to the network and Emma for being helpful, and Karina for being helpful in organizing everything, and also to Mark Davis from Monash University, who's also been part of facilitating that I'm even here in the first place. So I really appreciate that. And to Margaret for acknowledging also the traditional custodians of this land. I would like to pay similar tribute. I'm coming from a country which itself has a colonial history that it is never acknowledging, much less its colonial present with its claims on Greenland. So it is always very sobering to be in Australia. I am really, really happy to have this opportunity as well to share some thoughts from this forthcoming book with the title Data Paradoxes. It is a book about what happens when we are integrating data infrastructures. And now I know that's a hard sell, integrating data infrastructures. Who on earth could be, thrilled by the thought of reading about that? But it is not as dull as it sounds, I hope to convince you. And it's incredibly important. It's important not least because our lives are saturated with data, and policymakers are determined to make healthcare ever more data-driven. So we need new tools for contemplating what they're doing. And to get us started, and also to explain to you, how did I start to think that I should look into integrating data infrastructures, I will give you an example of what sparked my own curiosity. So it was, for example, when I was sitting in the audience. Imagine now yourself sitting here on the rows together with me, listening as the speaker says, "We need to disrupt all value change." And she's a high-ranking civil servant in the Danish healthcare system, and it's said with immense conviction at a big annual meeting for everybody who's something in health IT in Denmark. And the feeling of being given an order makes me straighten up in my seat there. And I can't help feeling puzzled. She's saying, without explaining what all these value chains are or what disruption will involve in practice, she goes on saying, we have the most amazing data resources in Denmark. But if we do not act now, we will fall behind. Mm-hmm. And she's not the first speaker I hear mention the fabulous Danish data resources and an obligation to disrupt. So what are amazing data resources that make them into an obligation to disrupt? And what type of future is it that she has in mind? Another afternoon, not long after, I'm attending a meeting. It's framed as an opportunity to discuss data-driven healthcare. And various researchers, they discussed the hopes associated with data in this meeting. And a guy sitting next to me leans over and whispers, "I would prefer a statistician to a doctor any time." And he's a healthy-looking young man, in his early 20s, and I notice variables on his arms, and he seems to be collecting a lot of data on his own health. But what kind of future healthcare is it that is in the minds of people who prefer a statistician over a doctor? What is it that they think they can achieve with data? So it was around 2014 that I began regularly attending all of these events. Events saying that they were about the future of medicine. And I have now become accustomed to people telling me that we are at the cusp, or even in the middle of a revolution. Informally, during breaks, or formally as part of silver-tongued presentations, they foretell an imminent state where ubiquitous computing means that practically any activity will give rise to data, where it will be possible to gather then data enough on individuals to predict the advent of most diseases, and where such predictions will facilitate prevention of diseases. So instead of waiting for symptoms to manifest themselves, now people will be warned of future diseases by data profiling devices. Personalized regimes will replace standard treatments, I'm told. Big data will replace evidence-based medicine. Artificial intelligence will replace human interpretations. Apps will sideline doctors on many issues. And in consequence, the story goes, healthcare will even become cheaper, more efficient, and people will live longer and healthier lives. And on top of this, the old-fashioned administration and governance can be cast aside and be replaced by smart algorithms designed to optimize performance. So in these prophecies, data just need a bit of statistical help to get the job done. Now, with the book Data Paradoxes, I set out to explore all of these data promises. What is perhaps most striking, however, is how nurses and doctors continue to do pretty material things. They work with people, not just with data. So there seems to be a profound gap between the narratives of data told in reports and at conferences and the everyday experiences of health professionals and their patients. The high-flying promises do inspire concrete policymaking. Yes, they do. But promises do not just trickle down through layers of practice to permeate everyday experiences as water soaks through clothes. That's not how it happens. Rather, promises interact with practices and experiences, and practices and experiences tend to bounce back. So to study what's happening, I needed to find a way of framing my study that would allow me to both explore these buoyant promises, pretty interesting they are, all the data gospel, we could say, and then the mundane, everyday experiences of healthcare. So I needed to find a way to do that without subscribing to one or the other. So in this talk, I wish to let you in on what it is that they call fantastic Danish resources. And I want to explore the tensions between the buoyant promises and the everyday practices and experiences, and in that way open up a discussion about how data infrastructures are changing healthcare. So how do I frame this study? I decided to explore simply who wants which data and what they use them for. I thought that's empirical, I can study that. So I took as my starting point of departure the basic empirical observation that more actors want more data, preferably of better quality, and on more people, but they often disagree about who should actually be allowed to use them. And for what? I call that empirical phenomenon for intensified data sourcing. And intensified data sourcing is both about big data, but not only about big data. It's also about mundane data practices. And my guiding curiosity has thereby been, what drives intensified data sourcing? And what are the implications for the governance of healthcare, for professionals and for patients? And as you might already have guessed, my pursuit of answer led me to paradoxes. It led me to conflicting stories, seemingly contradictory narratives about why people want data and what data intensification does. And first, it caused me a real headache. I was like, is it this or is it that? And then I realized that it's both, and that's the very point. And this is why I decided to coin the term data paradoxes and explore what happens when we're thinking of both narratives or many narratives as carrying elements of truth or validity. But first, I should just notice that I was certainly not alone while writing this book. Thinking is basically a social act. And if you like any of the ideas that I will present in the next 35 minutes, I'll probably got them in discussions with some of these excellent scholars. The people in the box are all part of a project financed by the European Research Councils. But a lot of more people have joined me in these explorations. One of them is even here in the room, Olsi. I can't list all of them, but really, I am immensely grateful for all the people who have shared their thoughts with me. And with that note, I can turn to the amazing data resources and why Denmark would be a good case for discussing reuse of treatment data for research and other purposes. What is it that the speaker at the conference talked about? Because Denmark would typically be associated with an idyllic scene like the one on the picture here. But already 20 years ago, Denmark became known for the opportunities for especially epidemiological research. Science called the entire country for a cohort study, and even the epidemiologist's dream. And as you will see, it says Denmark has gathered more data on its citizens than any other country. I don't know if that's true, but at least that's what it said. These are the amazing resources, and it depends upon a particular registry infrastructure and a high degree of digitization. So first, the registry infrastructure. The backbone was established in 1968, and it was free base registers only used for identification purposes. You see, it's on people, on dwellings, and on enterprises. It's a Statistics Denmark slide, this one. And as you would gather when looking upon that triangle, it was set in purpose, it was installed in order to do good taxing. But once you have identity measures for everyone and everything, it's a very useful thing. So today, and continuously, from 68 and onwards, every appointment in healthcare, social benefits, income, education, employment, everything uses the same identity number. And that also means that it can be linked And it can only be linked if the data are actually interoperable. And that also depends upon a high degree of digitization, that the data are actually digital. And Denmark usually ranks number 1 together with Singapore, and sometimes it differs a bit on how they measure, as the most digitized country on various world rankings. And digitization cuts across both public and private sectors, and both sectors use the same identity number. So in the book, I also describe how you can't go to a gym without having an identity number, right? And I can't remember really when I last received a letter, a prescription, a referral, or anything, from my doctor on paper, or with other things with public authorities. But this kind of thing doesn't, just happen all by itself. It is gradually growing out of a thing which seemed very, very, sensible in 1968. And then it just grew. So how did it come into place, this kind of infrastructure? How did we leave paper behind? The EU now wants to install this type of infrastructure throughout the EU. The stimulus package after the COVID is all about establishing data infrastructures, identifications, and data sharing options of the type in Denmark and in Finland. But it is described there as a technical and a legal issue. Define entitlements and connect the wires. And I want to argue that it's not enough to connect wires and establish entitlements. It grows out of a social texture as well, but also the social texture is co-produced with its technological embodiments. So the two are co-produced. When looking upon how we could see the different steps of creating an integrated infrastructure, I have suggested in the book that you could talk about, the early period was all about curated transfers. And that's the registers. That's a doctor saying, this particular piece of information belongs in the register. So they send information to in a digital way to a centralized register. And that was very useful for a lot of different purposes. But gradually, it started to turn into automated pooling and centralized platforms. And I'm going to talk about these two steps in the following 2 slides. First, automated pooling. It is when you, as a doctor, work in your own interface, and then basically the whole electronic health record or elements of it is automatically transferred to centralized sources. This is for quality databases, very useful, and it has saved people a lot of time. But this particular homepage here, which would be translated into health.dk, is started off as a kind of health services online, a place where you could find information about treatments and also like what is the waiting time for different doctors and that kind of stuff. But gradually, it was also seen as a useful place for having online access to your own health records for citizens. And in order for citizens to have that, you needed a backup of all the health records in all the various systems. So now you centralized with automated pooling all the hospital records. And then citizens can access it, but also doctors in other hospitals can, crack the door and get in there and ask for it. It's very useful, super helpful. And it's centralized pooling, which means that, you are not in control as the individual doctor of where the doctor ends, where the information ends that you produce. After automated pooling, we've also seen a move towards what I call platformization. And that is a shift where it is no longer a local system you work in, and then it's automatically pooled somewhere else. Actually, now it's the doctor that needs to log into the central system. So for a doctor to make prescriptions in Denmark, they log into the prescription register or platform. We do this for a lot of different things, including do not reciprocate orders and that kind of stuff. And what's interesting here is that with curated transfers, the doctor would be like controlling the curation of a particular point, but the main information remained in their local system. With automated pooling, everything is shifted, and the doctor loses control of where the information ends. But with platformization, you could even say that now the doctors are also becoming the subjects of control. They are the ones who are now locked to see whether they should have access to this particular piece of information. So it kind of steps in a loss of health professional control over the information. So that is the Danish data resources. Now, what's driving this data intensification? I mean, wouldn't this be enough? Some people might say. So I was trying to understand basically who wants more data now and what do they want to use them for? And I've spent actually 6 years, posing questions in all different kind of ways. And I get a lot of really, really good answers, a lot of really, really good things to use data for. And I gather them and I try to collect them and I categorize them and I ended up making a table. And this is just, with the most highest ranking, taxonomy of the purposes to which data can be used. And you can't read it. And that is the very point here, that there are simply too many purposes, too many things they want to use it for to give any easy overview. Each one of them very laudable. You can overgroup them into, like saying clinicians having, ideals about using them for health issues. You have policymakers and administrators who really see that they could use more data to support good governance. You have researchers who want to use the data to create new knowledge, and you have industry who have, I guess, also legitimate interest in one way or another in creating wealth. All good and laudable purposes. But it also means that data have become ontologically multiple in ways that we need to acknowledge, also in policymaking. Data do not just mean several things. They are several things, or rather they do several things simultaneously. Health data might be data on a patient's disease at the same time as it's data on the treating physician, the hospital, the laboratory that delivered the test. Data can affect each of these arenas differently, depending on who uses them and for what. So to accept ontological multiplicity involves investigating data not just for what they signify, but for the diverse effects that they have in several arenas at the same time, or for the same actors over time. And because intensified data sourcing implies that data can serve an increasing number of purposes, data then ends up being like cogs operating in several machines at once. And it can create a bit of friction. So this is why I think we can also tell paradoxical stories about data sourcing and data intensification. We can say both that they thrive on a claimed need for evidence, but also that all the initiatives for data investment tend to be rather poorly backed by evidence themselves. We can see that data empower citizens, but also that in other cases it disempowers citizens. And I have a longer list of such paradoxes. What I think is really, really helpful with paradoxes is that they invite you to accept ambiguities and to ask questions, not thinking that because it did this in Utah, it will do this in France, but rather it might do different things when interacting with local practices and experiences in other ways. So the book explores all of these paradoxes with empirical examples, and it shows why we cannot get evidence from contexts in context-independent ways. Instead, really, we need to be able to exert judgment still, using data, but not being data-driven. So I could also illustrate this with the multiplicity of data with an example. And an appropriate example might come from this guy, who is the director of the National Health Authority. He said in 2016 that psychiatric diagnostic codes among the young are no longer medically valid. That's a pretty, big thing to have, from a country with amazing data resources, that the director of health comes out and says, no, I'm sorry, they're no longer medically valid. But his point was that we had started to use diagnostic codes for too many purposes. So for municipalities to have good governance, they needed clear criteria for when students should have extra help in school. And that means that you could go to your GP and try to persuade him into giving your 10-year-old a diagnostic code. And then we would have clear criteria for when people were getting extra pedagogical help. But the thing is that turned the whole diagnostic criteria around. And they were to serve good governance, but then they could no longer serve as good cogs in the research engine, right? We could no longer trust them in the same way. But it's also worth noting that what opens a door for the child at the age of 10 might close other doors. So between 2009 and 17, there was an increase of 72% of young men who were denied access to the military because of psychiatric diagnostic codes acquired in youth. We have long waiting lists for people to get a driver's license because for security reasons and good governance reasons, we make sure that people with a psychiatric code can't just get a driver's license. So codes start operating in too many machines at the same time. And then it causes friction. So to think with paradoxes is also about embracing opposing stories. It's doing both good and something which is not so good for different people or over time. Patients, clinicians, and administrators, they sometimes use very similar data to tell almost contrasting stories about what data do or mean also. We also need to embrace that. Paradoxical thinking implies really embracing these ambiguities. And ambiguity then contrasts with the contemporary policy ambition about being data-driven in healthcare. That promulgate ideas about simple and unambiguous answers. But the policy ambition is typically to resolve uncertainty with data. Give an answer about an effect, yes or no, or about efficiency, low or high. And instead of promoting such answers with the type of either or, I think it can be helpful to start thinking in both and. Because it's stimulating to consider these paradoxes. It invites questions and curiosity. And sometimes, a paradox can be solved in a very simple manner. The same data can produce opposite effects in different places. Some places the story is red, some places the story is white. But it can also be for different people or within different periods of time. But in other instances, the paradox becomes a reason for rethinking the power play as such. Because what's at stake in the tensions between opposing stories? It creates also particular options for the people who can thrive on the ambiguity, because it gives a room for action. And also it can facilitate power to simultaneously say, we need data before we can decide anything about what we can do about inequity in health, for example. We can't do anything about that before we have more data. It buys you time in that sense. But at the same time, we can invest billions of euros in digitization because otherwise we might not be part of the future. So they are like living on the ambiguity of both needing, data as evidence and not needing it for the investments and the decisions they make right now. But I really want us to be able to tell easy stories as well. We also need to be clear that we can't just say everything is more complex. And a paradox is also a way of sometimes saying, yeah, it both empowers and disempowers. Try to figure out what happens in your context. For whom? According to which criteria? So, the chapters in the book each have a topic of promises of living, of work, of experiences, wisdom. And I begin the data promises chapter with all the hyperbole promises related to datafication and this paradox of investments being made without any evidence, while the claim is that we need to make the investments to get future evidence. I then discuss data living and how data infrastructures came to permeate everyday decisions. And I here focus on the paradoxical ways in which datafication both empowers and disempowers patients, but also uncover and cover up their concerns. It does both. In chapter 3, I focus more on the health professionals and the contradictory stories about their work. And in chapter 4, I'm focusing more on things that I think we need to explore in much more depth, namely the phenomenological engagement with data. How do we actually experience data? We are not computers. We are not processing them like computers. And in chapter 5, I reflect on how to use data well or wisely. And then in chapter 6, I reflect on how each of these themes and all the points I made so far was either confirmed by the pandemic experience or challenged. And then I end with some reflections on the so-called ethical debates about ethics. But before I close now, I'll just move a little closer to some practices and experiences, beginning with data work and then taking data living. And it's just a few examples. But again, it is striking how we have the audience in which I took you before. We are sitting there and we're hearing how datafication will give less work, it'll give guidance for action, it will be seamless and quick, and automation will make sure that we arrive at the future of medicine. And then when you are out among the healthcare professionals, they will talk about spending ever more time on data. A lot of it described as meaningless work, a documentation burden, a bureaucracy, and absurd systems. And how can they both be somehow true? And this is one of the things where we think about just less work or more work. The paradox is actually easily resolved if we just think about some of the well-known established insights about healthcare information. For example, Berg and Gorman's all work on the law of medical information, which states that the further information has to be able to circulate, the more work is required to disentangle the information from the context of its production. Super old, very easy insight, you know. It's easier for me to write a post-it for myself to remember something in an hour than to write something that should end up in a file for somebody else to read, or something that should go all the way up to the regional or state office and somebody else should be able to understand it in 20 years' time. It's really a question of the health professional getting more work on documentation in order to facilitate people at a distance to be able to understand the information. It's not that hard to understand, but it has implications. And these implications involve also the other paradox of tightened control and organizational disintegration. Because as people start to have ever more work with documentation and they are being controlled through the ways they document, then they start documenting in new ways. So a quality coordinator, for example, said to me, you know, times are changing. People are getting more used to having everything out in the open. So if you haven't documented it, somebody will be chasing you down asking for it. So, all right, I think, all right, we got the data right. That's lovely for us at a distance who wants to use it as researchers. But then she continued, I actually think you can hide as many things today as you used to be able to, because you could just produce bad data, invalid data. Then the documentation is there. It's just as if a slippery slope has somehow opened. The hospital manager was even more frank. He said, one thing is certain, you become very creative. If you're pressured on something you can't possibly deliver, you cheat. So, while we are thinking that we can see ever more things with data, we are also obscuring our sights ever more in ways that are very, very difficult to interrogate, because the data is what we have for figuring out what's happening in health services. So this is, the practices of healthcare, but then there's also the people experiencing it at the receiving end as patients. And I could speak for hours about that, but I should say that for most Danes, generally this means it's super seamless. It's so easy. Oh, it's lovely. I don't have to, keep track of my, prescription notice or anything. I can go into any pharmacy in all of Denmark and just say my personal identity number, and they can pull it up and get the medicine for me. It's nice for many of us, and for some, it's not. And I'll give you just this one example as I turn to the data living kind of story. It's the story of Sebastian. He's a young man who acquired a diagnostic code as paranoid schizophrenic in his early youth, apparently by error. But he keeps having this vague feeling that it could be seen by others. He cannot know what people see on their screens. When he's in the pharmacy, he doesn't see their screen, right? When he's talking with his general practitioner, the screen is hidden to him. So he's worried about the implications for how professionals might view him. And would it influence their judgment if they think he might be paranoid schizophrenic? And he explained then that you can't help wondering whether it affects how people view you. For example, last year I broke my wrist, and as I enter the emergency room, I get the impression I can't be sure that it's true, but the doctor, after having viewed the records, dismissed my case. The way I was treated, there was something. I couldn't work it out at the time, but it was as if I wasn't being treated objectively. And there was this nurse, she was really rude. And I tried to get an x-ray, but the doctors just said it wasn't broken, and I was sent home. And it turned out it was broken in 2 places, actually. And it's a little annoying if they were somehow colored by the psychiatric diagnosis. Now, you should note how Sebastian does know. He's not sure the health professionals were biased because he doesn't really know what they knew or what they'd seen. But this is also an element of intensified data sourcing. Data ubiquity is not confined to the data that actually move. They are also shaping the way in which we move in data-saturated spaces through imputations and guesses. So, to conclude, with this book, I want to reconnect policy, practice, and experience, kind of close in on the gap between the hyperbole and the everyday experience. And mundane data practices really are far from the data gospel. But the gospel does legitimize a lot of changes. And these changes might not be as disruptive in the short run as claimed. Rather, they end up being just investments in infrastructure. But infrastructures might be more disruptive in the long run than imagined by policymakers, but in other ways where we stop believing in the data that we have, ways where we stop trusting the health professionals in front of us. And these infrastructures involve shifts in work, in medical attention, and in epistemic trust. They also involve shifts in the conditions of care under which we live as citizens, our patient rights, and what is even meant by the notion of confidentiality. So I've called this book Data Paradoxes because I think we need to accept that with intensified data sourcing and integration of data infrastructures, data do several things at the same time. They are ontologically multiple. And I want us then to embrace these paradoxes rather than opt for the easy answer, which is like either this or that. And if we do not accept the easy answer, we have everything we need to learn to pose better questions. Questions about what works locally. What is it that I don't know? It can stimulate our curiosities and also expect that there will be unexpected consequences of intensified data source. And on that note, I'll thank you for your attention. And the book I thought would be out now, but apparently it's April 18th. So thank you.
Radhika, do you want to
Sure.
do the discussant thing?
Yes.
The thing.
Discussant thing, yeah. Actually, some time back, I remember reading, and I don't know if I remember this right, but reading in the newspaper that we actually don't know what the leading cause of death in Australia is, because on the death certificate, what usually comes is like kidney failure or something, like renal failure or something, which is the immediate cause of death. But actually, the actual cause of death, which led to that renal failure, might not be registered. So that I think it was whoever's the medical authority in Australia that said that we actually don't know, what the leading cause of it. So I was trying to collect stories or statistics where it's like absurd, and this was one of the stories that popped up at the time. But anyways, I was reminded of that, Klaus, as you were talking. But first, I want to congratulate Klaus on this really amazing book. I thought that I would be able to read all of it before now, but I found that it was so good that I had to slow down all the time. And it was for two reasons. One is that, really amazing, like the content itself was great, but you also have such an engaging style. And the other thing was that I do work in education, in the field of education, but very similar kind of data work. And I was just kind of jumping out of my chair all the time saying that that's exactly how it is in education. So it kind of really slowed me down as I was trying to read. So I have, the excellent quality of your book to blame for my not having been able to read the whole thing. But I read a lot of it. I read, much of the book. So, and also, of course, your presentation had so much information in it. But I'm looking forward to reading all the rest of it and then, having this discussion of the parallels. So I did find that there are many, many parallels between, what's happening in medicine, what's happening in education. And you mentioned, in this, you mentioned platformization as well. And that's one of the big things that people are writing about in education. But there's a lot of stuff that people are not writing about in education in terms of data. In education, most of the data we are generating globally, that's really for monitoring and incentivizing. It's really for administration. If you look at those four things, what I find is that the data that is required to actually improve teaching, there's very little of that being generated at any kind of scale. At the same time, because UNESCO Institute of Statistics and monitoring for SDGs, etc., they all want data about everything. There's a whole lot of people at the level of the school that are the demands are being made on their time and on their energy to produce data, more and more data. I was doing some research down in Karnataka in India, and I went down to a kind of a small town, and I was talking to the principal and the teachers there. And the principal said that, they have a number of, they have to do lots of things besides teach. They only have 9 hours for administration. They also, headmasters, they also have to teach. And in those 9 hours, they also have to do the midday meal scheme. They have to they have to distribute vitamins to children. They have to get the uniforms, textbooks, all sorts of other things that they have to do, including manage their school and the teachers. They have parent committees, and they have to, sending the parents don't attend. They can't spend any money unless the whole committee signs. So they have to go and, send out students to go and knock on the doors to find them. It's just mad. And they say, so when they keep, and then they say, we put in the data, despite our low internet speeds or not having electricity, having to go to the cyber cafe to input data and all this kind of thing. But at the end of all that, we turn around and the next week they're asking for the same data again. And they said that, so when you said, about the accuracy of the data, this guy actually said, we said, okay, fine, we'll give you data, but don't ask us about the quality of the data. That was his statement. So it was very reminiscent, in that same thing is happening in education again as well. And you mentioned in the book also about the cost of data production, and that many of the people in government and people in administration don't just recognize. They just feel that it's worth, whatever the cost is. And it's not only the monetary cost, but also the cost of labor. And you had this amazing picture of that, of the doctor or the nurse at the window, with the, it was very much the same sense of, burdening people with data production. Anyway, some years back, I did research on secondary analysis. So PISA is this big international, assessment that gets done, and they talk about having the largest database on, global database on performance and on systems and, so on. And they keep encouraging, actually, they've set up a fellowship for people to come to Paris to use their database and to do secondary analysis of data. So and also ESRC encourages, ERC rather encourages, secondary analysis. There's this idea that we have such amazing data all over the world, and people should be, you use the word mining, I think, at some point also in your book. So they should be using these data to do other stuff, to do secondary analysis. So I became very curious about what kind of practice is the secondary analysis. What does it mean to do secondary analysis? So in my head, I was imagining this big cauldron, of data and people rummaging through that. So I actually called my project Rummaging Through Data. And that was the same. I felt that those, data got in there, and they were very, they were like pieces of Lego. They were kind of completely decontextualized so that they could sit there. You didn't actually know all the baggage that came, that produced that piece of data. You didn't have any understanding of the context. You didn't have any understanding of the meaning of it, or, some was raw data, some was processed data, like everything was just in there, and people just mashed them together and produced new knowledge. And it was like a highly promiscuous data that could combine with anything and, travel anywhere and be used by anybody. So I had, this sense of integrated data. I was thinking about how do these different bits of data and different systems actually connect with each other, and I think similar problems of kind of losing their provenance or losing their histories, losing their context, and then having to kind of disembodied kind of and then in medical terms, I suppose disembodied is a particularly kind of interesting thought of data being separated from the body. So in that secondary analysis, I eventually wrote a paper which I had grandly titled something like mathematically defensible but ontologically nonsensical. But I had to change the title to get it publishable, and I think I ended up calling it something very benign, like thin descriptions. So anyway, your insights about intensified, what was it, data sourcing, IDS, I started to call it, resonates a lot with how data are impacting education. We also find that data demands are producing exploitation of labor. We also find that data demands are making people cheat. And there's many, many examples of that in education. They're also sucking up huge amounts of money and attention. And they're all, one of the things that we found was that they're redistributing trust. In fact, in one of the papers that we looked at in India, we found that accountability systems based on these kind of data only work if they can produce distrust amongst people. So they have to rely on people telling on other people in order for their accountability system to work. So they have to put up something that is transparent, and somebody has to notice and report that that is not accurate, and that they're relying on that. And then it doesn't work because people locally actually need to trust each other. They can't afford not to trust each other. And so actually the transparency doesn't fulfill its promise. But anyway, I wanted to raise like 6 points actually that and you can choose, maybe 1 or 2 or more that to discuss now. One was that you mentioned that one of the issues with the way IDS works is that it uses a flat ontology. Now we did come up in the talk, but you talked about that in the book. And that to me was quite interesting because in some ways you talk of STS, or at least ANT, which is a part of STS that I am kind of familiar with. Also, we talk about using a flat ontology, and that flat ontology enables us to kind of get past the dichotomies, right? So, but you were talking about the IDS itself using a flat ontology, which is problematic because it loses the context and so on. So I found that itself paradoxical in a way, yeah. And I thought that's one that might be interesting to talk more about. The other is, I'm always, I collaborate with many colleagues in Europe, and one of my colleagues in education from Bristol, she just recently got 2 million euros, 2 million euros actually, to do some educational research, and that's unheard of in Australia. I get so jealous of people in Europe getting large sums of money, but as you did, and I was just thinking about the methodology, and you, of course, you've cited some of your work with Brit Winterday. And I have read their book with her book with Jensen, and I was just thinking about they talked about the methodology that they had to use, because now what's happening is that you have kind of globally distributed system infrastructures, and they were trying to study that ethnographically, and you were also dealing with this very large. I was just thinking about what kind of ethnography or anthropology, or what is possible in these kinds of things. And I couldn't get to the methodology chapter, so I'm going to cheat a little bit and ask you to talk about that. The other thing was that so when I wrote thin descriptions, I later on had an opportunity to talk with some developmental economists out in University of UC Irvine. One of them, he was very upset with me. One of the things he said was that, yes, I use secondary analysis. I use a PISA database to do secondary analysis, but I do not rummage, which was really interesting. But anyway, what he felt was that he said, if you want to go to a foreign land and do some research, you would at least bother to learn their language. So what gives you the authority to come to my world and judge me? Was this question. So I just, wondered, because my own interviews with psychometricians and statisticians and so on have always been very interesting. They were not incensed that I was. In fact, they were quite pleased that I was asking them about their practices, and they were quite happy. It gave them time to reflect on their own practices, and usually they were quite pleased about that. But I just wondered about this a tension between being on the outside, so that you can see things that the what is familiar to them becomes strange to us, and so that's a useful thing. But on the other hand, are we able to really understand? Like, did my developmental economist friend have a point? Should I have learned his language to understand him? So what kind of preparation, I suppose I'm asking, do we need to be able to do good research in this new world of intensified data? And then I want to ask a question about, this is like here in Australia, and I don't know if it's like that in Denmark, I hope not, but we're hounded by this question of impact and engagement. What's the impact of your research? Whom have you talked to? How many citations is not enough? How many policies have you changed? I was like, yes, I do, I do global policy networks, research in global policy networks. And I wrote a paper, so UNESCO changed its entire plan, right? Yeah. Like, how do you have that? You won't have that kind of impact. But I just wondered about, from your perspective, who did you want to read the book of, for those, 4 groups or more? And what do you have spoken about that actually in the book, but I thought I'd, ask about that. And the other paradox I noticed actually was that you have these integrated, integration is, part of what is happening. But I think at the same time, is there also fragmentation going on? And that was one of the thoughts that,
disintegration. Organizational disintegration.
So that's
one of the paradoxes.
So I don't know whether fragmentation is even something a little bit different to the disintegration. It's like the data itself, the kind of losing its integrity or its wholeness in some way. I don't know whether you're, because of your use of the word wisdom, I was reminded of Eliot's, where from the rock, he says, where is the wisdom we've lost in knowledge? Where is the knowledge we've lost in information? And of course, we can ask, where is the information that we've lost in data? But I was also reminded, because Ezrahi has used that same kind of, he's riffed off the same thing. And he actually went on to say something about outformation, not information, but outformation. And he talks about outformation as, as the way in which information is, can cause shared fictions, a set of shared fictions. And I felt that might be something that's that has always interested me, actually. And particularly if you add in the new media and the immediacy of things, and the aesthetics also, kind of short, sharp bits of data. And I wondered whether that might be a useful thing to pursue. Finally, I just want to say that I felt that your idea of using paradox, was really brilliant. I feel that it, we keep writing in STS ontologically, multiple ontological, but that doesn't mean anything to, to the policymaker you want to talk to, or the data scientist you want to change, whose mind you want to change. But I think acknowledging the paradox, because they will all acknowledge that, they'll all understand that idea of a paradox, because they've all encountered it. And I think that's brilliant. But also one other thing that you did, which I don't know if you used here in the talk, was this metaphor of using this data intensification as a drug, right? The metaphor of drug.
No, I didn't take it up here.
And I felt that was absolutely genius, because you talk about how thinking of this as a drug helps you to think about that, and the fact that it needs to be regulated, that it needs to be used with caution, that it needs to be prescribed under expert care. And I think that's a really useful way to encourage people to think. And I think it's simple and it's profound, and I think it's also highly useful. So again, congratulations. I've madly highlighted lots of parts of the PDF, waiting to go back and read those other things that I couldn't finish reading before I got here. But I also want to say that just the style of your writing is just so beautiful. It was so engaging, and I'm madly jealous, but also very happy to read the book.
Oh, yeah. Thank you very much.
So can I say once again, the book is out on the 18th of April, 2023.
I just got an advance.
And
well, thank you very much for those very generative and generous comments. I'm going to bring things to a close now. First of all, I do want to thank Radhika for her beautiful discussion really.
and thought
Thank you.
of Klaus's book, and bringing in the parallels between so many of us come from the education world to the healthcare world. For those of us who sit between, and we get the best of both. I also wanted to re-thank SSN for hosting, sharing, organising, Monash for bringing Klaus out, and finally, Klaus, of course, yourself too, for generously sharing your time.